first of all, as a screening parameter. So somehow you have to identify the AL amyloidosis patients. I'm still talking about AL. And because awareness is a big problem, right? So, and most of the patients we get from our cardiologists, because they have this widely available technique of echocardiography. So this is very central, and I don't think there's a debate about it. But going on, because a cardiologist can only see the ultrasound, you can say, well, that's suspicious, but we still have to, go a step further, confirm, look if it's AL amyloidosis, or if it's what kind of amyloidosis it is, if it is, or if it's some other kind of deposition disease, for example, or if it's hypertension and so on. So, and that's really the next step where we're at. And I think it's very exciting. So I've seen some very interesting data as well about that. Maybe you can get a specialist about it, because so far we usually do the bone scintigraphy, but it's really just a surrogate for AL or for amyloidosis in general, because what you're looking at is there a signal in the heart? But I think we've come to a point where we can positively say that it's probably just a surrogate for the calcifications that occur subsequently to amyloidosis. So it doesn't stain the amyloidosis itself, but more, the sequelae of it. So, and the next step obviously is to actually find some tracers that give us insight about the actual amyloid load in the organs. So far we only get an information about the heart, but hardly about the liver, hardly about the kidneys and so on. So that's a very important point, and I see some good papers on it. But also maybe it's possible to differentiate, and that's a point we're not at yet. But there's people going on about it, and I think it's going to be very central, because currently talking about awareness, I think for non-experts, kind of complex diagnostic algorithm for amyloidosis is hindering in some way. And to make that easier, for example, with imaging, is very central.